All right. Hi, everybody. Welcome. We have a very special session today where we're going to have our second year bachelor's MS-PH students present their master's essays. So this is the kickoff session of master's essay presentations for the year. I say every year that this is one of my favorite times because we get to see work presented by students that they are most passionate about and get to see their presentations that you all have been working on for quite a while. So thanks all for joining. I'm going to go ahead and just kick right off. We're going to do 10 minutes per presentation. We have 4 presentations today. And then after each 10-minute presentation, we'll do 5 minutes of Q&A. So get your questions ready. So first up, we have Grace Lee. So all of the students who are presenting today, Grace did her undergrad at Johns Hopkins University, and she majored in public health studies with a minor in bioethics. And so, Grace, I'm going to go ahead and hand it over to you. Are you able to share your screen? Perfect. Looks good.
All right, thank you so much. Hi, everybody. Today I'm going to be discussing attacks against healthcare and armed conflict, legal and institutional strategies to safeguard health in Ethiopia. So I just want to go over some of the research objectives first. This study had 4 primary aims. First, to examine attacks on healthcare during the Tigray conflict in Ethiopia. Second, to assess the public health implications of these attacks. Third, to evaluate existing legal frameworks designed to safeguard healthcare in conflict settings. And finally, to propose strategies that could strengthen the protection of healthcare during armed conflict. So I want to start off by defining what attacks against healthcare are. They're defined by the World Health Organization as any act of verbal or physical violence or obstruction or threat of violence that interferes with the availability, access, and delivery of curative and/or preventive health services during emergencies. So these attacks can take many forms. Common examples are physical and verbal violence against health workers, destruction of medical facilities, and attacks on medical transport systems like ambulances. Globally, these incidents have been rising. In 2024, over 3,600 incidents of violence against healthcare were recorded across 36 countries, which is the highest number that's ever been documented. International humanitarian law is one of the most important bodies of law governing these situations. So, IHL regulates the conduct of armed conflict and seeks to limit its humanitarian consequences. A central component of this is the Geneva Conventions, which establish that medical personnel, healthcare facilities, and medical transport must be respected and protected at all times and must never be deliberately attacked. The Rome Statute of the International Criminal Court also states that intentionally directing attacks against these protected entities listed here constitutes a war crime. So together, these frameworks provide a foundation for accountability in cases where healthcare is targeted during armed conflict. Now I want to introduce our case study on Tigray. Tigray is a northern regional state of Ethiopia with a population of about 6 million people. It has historically had an extensive network of public health facilities serving both urban and rural populations. And in November of 2020, armed conflict broke out between the Ethiopian federal government and the Tigray People's Liberation Front, which is a political party and former ruling military organization. And this conflict was primarily driven by political tensions and disputes over an election that took place that year. And as a result of the conflict, the region experienced mass displacement and, as we'll see later, a near collapse of its healthcare system. Even after the formal end of the conflict, violence against health has continued to be reported in Tigray and other parts of Ethiopia. Violence against healthcare took form in multiple ways in Tigray. By mid-2021, approximately 75% of hospitals and 89% of ambulances were reported to be non-functional. This was the result of lootings and deliberate destructions of facilities, as well as occupation of hospitals by armed groups. By 2024, reports suggested that only around 2% of medical facilities remained fully intact and functioning. Healthcare workers were also directly targeted. At least 37 workers were reported killed and 78 were injured, though these numbers are widely believed to be underreported due to communication blackouts and restricted access to the region during the conflict. Another critical factor was a severe humanitarian blockade, during which very little, if any, humanitarian assistance was allowed to enter the region. This blockade severely disrupted the delivery of essential medicines and equipment, as well as vaccine campaigns, and left many hospitals without essential resources. So, as you might expect, these disruptions had profound public health implications. One major impact on maternal and child health services was that routine services like antenatal care were largely suspended within months of the conflict beginning. For example, antenatal care coverage dropped from approximately 94% before the conflict to about 16% during the conflict. Similarly, childhood immunization rates fell to roughly 10%. And as a result of this collapse, the region experienced outbreaks of vaccine preventable diseases. Chronic disease management were also suffered. Approximately 79% of chronic care services were disrupted, which greatly affected treatment for conditions like HIV, diabetes, and tuberculosis. In terms of current legal frameworks that prohibit attacks against healthcare that apply to Tigray, Ethiopia is formally a party to several international legal agreements, which are legally binding, including the Geneva Conventions. Domestically, there are legal provisions that implicitly prohibit attacks on healthcare, including relevant protections within the Ethiopian constitution. The Cessation of Hostilities Agreement, which is the peace agreement signed, formally required parties to halt hostilities and allow humanitarian access to affected populations. Unfortunately, despite these legal measures, serious enforcement gaps still remain. Ethiopian laws do not explicitly criminalize attacks on healthcare, which greatly weakens legal accountability. This also contributes to a broader cycle of chronic impunity where violations are documented but rarely investigated or prosecuted. So, for example, there was a Human Rights Watch report in 2024 that identified multiple perpetrators, documented extensive evidence of attacks against health infrastructure, yet no significant prosecutions have occurred. External oversight is also weakened. The UN Human Rights Council did not renew the mandate of the International Commission of Human Rights Experts on Ethiopia, which was previously the only primary international body tasked with investigating human rights violations in the country. So all of these factors contribute to a serious trend where attacks on healthcare go largely unpunished, which reinforces systemic vulnerabilities and severely undermines public health. So now I'm going to offer a couple of recommendations in light of these findings. The framework that we're working under is human rights law, or HRL. HRL is the body of international legal norms that protects the fundamental rights and freedoms of individuals at all times, including during peace and conflict. This differs from international humanitarian law, which applies specifically during armed conflict. So by expanding legal protections beyond periods of active hostilities, this framework creates ongoing state obligations to protect the right to health. I think an important benefit of this framework is that framing healthcare protection as a human right increases political legitimacy. Specifically, this approach aligns healthcare protection with broader domestic priorities like preventing health system collapse or reducing population mortality, which can help secure political buy-in. The primary recommendation I offered in my research is the explicit domestic criminalization of attacks against healthcare. Research consistently shows that legal protections are frequently violated when they exist only at the international level. There is comparative evidence from countries like Colombia and the Philippines, which have incorporated protections for healthcare into domestic criminal law and have demonstrated that explicit national legislation can strengthen accountability and deterrence. So for Ethiopia, this option would be a critical step toward improving enforcement. However, we must also recognize the reforms should account for Ethiopia's political sensitivities and operational realities. So this is where some of those operational strategies come in. One of them is that initial reforms should focus on strengthening normative protections before introducing criminal penalties. So, for example, a good first step would be to explicitly recognize the idea of medical neutrality in domestic law. So, recognizing that healthcare providers must be allowed to treat patients impartially without interference from military actors. And then once these protections are established, specific criminal offenses could then be codified in law. These should include attacks or harassment of healthcare personnel, damage to or misuse of healthcare facilities, obstruction of medical transport, and disruption of essential health infrastructure. I want to conclude by discussing some key takeaways from this work. First, attacks on healthcare have severe and long-term consequences for public health. I think this is an area that currently remains largely understudied, especially when it comes to how these attacks influence maternal, child, and reproductive health and the health of displaced populations. The second takeaway is that while international humanitarian law provides important protections during armed conflict, it does not guarantee healthcare access or system continuity. Human rights law complements IHL by imposing ongoing obligations on states to ensure the right to health. And finally, while domestic criminalization is essential for Ethiopia, context-sensitive operational strategies are necessary to ensure these reforms are effectively implemented. Thank you so much for your time. I'd like to acknowledge my reader, Dr. Amen, as well as my advisor, Dr. Cardona, and my family for supporting me throughout my graduate studies. And if you have any questions, please let me know.
Thanks, Grace. I will open it up for questions. All right. Well, maybe I'll start us off. I guess I have a question about you described the situation of what was going on with healthcare during the conflict,
Mhm.
and I'm just wondering like where did you find that data? Because I know that often if there is a conflict that can disrupt data collection, and so did you have trouble finding out what the impact even was?
Yeah, the methodology is really one of the key barriers in collecting reliable and comprehensive data in these settings. So certainly, we can't say for certainty that this is comprehensive data, but a lot of important work comes from humanitarian and human rights-based organizations. So organizations like Médecins Sans Frontières. And then one of the reasons why I wanted to pursue this research was I was doing work with Physicians for Human Rights, which is another organization that does collect research in these settings. So they play a very important role. There are also international mechanisms to survey attacks against healthcare and sort of provide an ongoing database. So the World Health Organization has what's called the SSA, which essentially is a running surveillance system for attacks against healthcare. But in the literature, there is a lot of critique on sort of the methodology of how these attacks are um, categorized differently based on different methods of data collection. And so different attacks can be defined according to who's collecting the data. There's also been critiques of a reliance on secondary data instead of primary data collection. So there are certainly a lot of gaps here. I think as international recognition of the severity of these attacks and the impact that it has on public health, I think as that recognition increases, there has been increasing efforts and better and stronger surveillance systems to track these attacks. And certainly, we're not at a point where we can definitively say this is the full scope of the impact that these kinds of conflicts have had on healthcare systems and health workers and whatnot.
Thanks.
Mhm.
Any other questions for Grace?
Hi, Grace. I have a question. So, in regards to the collapse of the healthcare infrastructure and things like that, do you have any data about what it's been like to rebuild that infrastructure and whether or not this data has been helpful in promoting those efforts or not?
That's a really great question. Currently, Ethiopia is still in very much sort of a post-conflict recovery stage. So, a lot of this is, I think, still ongoing in terms of how much it has recovered. I'd say like a marginal amount. I think very recently there has been sort of an open call for financial aid in terms of recuperating some of these health systems because it's still struggling, given all of the other factors going on, like the political struggles. It's been really struggling financially to recover its health systems. But I think you make a also really great point in terms of leveraging this kind of data to advocate for changes. I think the biggest barrier, though, right now, rather than political buy-in, is or sort of a lack of acts or responsibility on the government to want to act. I think it's more so that the resources are so severely limited in this sort of post-conflict stage that the administration's been struggling to kind of do it independently. So there have been open calls to charity organizations and other humanitarian organizations to kind of help in this effort. And that's certainly that I think a strength of international cooperation is that it can lend itself to these kinds of collaborative efforts. Um, but yeah, it is sort of an ongoing effort to kind of recover from so much damage. And there is still violence against healthcare going on right now. So we're not completely sort of in the recovery phase in terms of all of those attacks have been in the past. There are instances reported in Tigray and other areas around Tigray of independent military organizations that are attacking civilians and healthcare systems. So,
Right. Thanks, Grace.
thank
Congratulations
you.
on presenting this work, and well done. We're going to go to our next presenter, Amelia, and she also is a graduate of Johns Hopkins, majored in public health with minors in both psychology and German, and she's going to present today about developing digital health tools for sexual health promotion.
Perfect. Are you able to
Yep,
see?
looks good.
Awesome. Oops. Okay. Great. So, hi, everyone. Thank you all for being here today. My name is Emilia, and I will be presenting my scoping review examining how human-centered design is being applied in the development of digital health tools for adolescents and young adults, particularly for sexual health promotion and STI prevention. So, why does this topic matter? Adolescents and young adults experience a disproportionate share of STIs in the United States. In 2023, individuals aged 15 to 24 accounted for nearly half of all reported chlamydia, gonorrhea, and syphilis cases, even though they represent only about a quarter of the sexually active population. This high burden is concerning because untreated STIs can lead to serious long-term consequences such as infertility, pregnancy complications, increased risk for certain cancers, and other chronic health conditions. And preventing STIs among young people is also complicated by barriers that occur across multiple levels, such as limited sexual health knowledge and stigma surrounding STI testing and treatment. And there are also structural barriers such as transportation, financial costs, and limited availability of confidential, youth-friendly services. So together, these barriers highlight the need for innovative approaches that better reach and engage young people in STI prevention and care. So why digital health tools? Digital health tools such as mobile apps, websites, and text messaging programs have emerged as promising approaches to address barriers to sexual health education and care for young people. And digital platforms can provide private access to information, allow youth to engage at their own pace, and potentially connect users directly to testing and healthcare services. However, the effectiveness of these tools depends on how they are designed. If digital interventions are developed without meaningful involvement from young people and end users that they are intended to serve, then they may not align with user preferences or real-world needs. And this can lead to lower adoption, poor usability, and limited sustained engagement. So as a result, ensuring that digital health tools are designed in ways that reflect the lived experience of youth is necessary for success. And this brings us to human-centered design. Human-centered design offers an approach for developing digital health tools that are closely aligned with the needs of end users. It is rooted in participatory design principles and emphasizes empathy, collaboration, and iterative development. And instead of designing solutions from the top down, human-centered design focuses on understanding users' experiences, challenges, and needs, and then involving them directly in generating and refining solutions. And so in the context of adolescent sexual health research, human-centered design has the potential to improve the usability, trustworthiness, and real-world relevance of these digital health tools. And so the goal of this scoping review was to better understand how human-centered design is currently being used in adolescent and young adult sexual health research. And specifically, it aimed to identify the methods implemented, reported outcomes, and the methodological or practical challenges, because understanding these patterns can help inform future development of youth-centered digital health interventions. So this scoping review included studies identified through searches in PubMed and Embase, supplemented by citation searching. And so you can see my search engines on the left. And studies were included if they were published between 2013 and 2025, focused on adolescents and young adults ages 12 to 25 years, described the development or adaptation of a digital health tool focused on SRH, and was published in English for my own translation purposes. And studies were excluded if they did not meet these inclusion criteria. And so after reviewing and screening titles, abstracts, and full text using Covenants, 21 peer-reviewed articles representing 19 studies met the inclusion criteria. And the most common reason studies were excluded in this process was because the study population was not within the age range. And in the end, the studies in the review were conducted across several countries, including the US, Canada, England, Kenya, Nigeria, and Rwanda. So some characteristics of these studies included that the digital sexual health tools for youth were developed as mobile applications, web-based platforms, or hybrid mobile web interventions, with native mobile applications being the most common format. And two interventions used a multimodal intervention combining delivery channels such as web-based platforms and text messaging. And the majority of the literature focused on early to middle stages of development, such as formative research or design phases, and usability testing or development phases. 15 of the interventions were new digital health tools created specifically for that target population, while 6 focused on adapting or refining existing platforms, either for new populations or new delivery formats. And most tools were designed for community-based self-directed use, where youth could access the information and services on their own time, and only one was integrated into clinical settings as a point of care intervention. And lastly, all tools incorporated educational content, but only about half incorporated direct linkage to care services. So to further discuss findings, studies employed a wide range of methods throughout the development process, and some patterns emerged. For example, during early formative phases, they focus on understanding user needs and defining problems. Studies predominantly used interviews, focus groups, surveys to gather contextual information and identify pain points. While in ideation and prototype phases, they use co-design workshops and creative methods like visual storyboarding, allowing youth to actively contribute to solution generation. And during prototype testing and refinement, usability testing, think aloud protocols, and so on such as structured questionnaires were employed. And some studies utilized youth advisory boards and even incorporated expert review in parallel with youth engagement to ensure clinical accuracy and theoretical fidelity. Youth involvement also varied across these studies. Some involved youth primarily as informants, some as testers, and some as design partners throughout every process of the design and prototyping and creation of the tool. And some patterns of tool type and age restrictions were also evident in a few studies. The digital tools that incorporated direct linkage to care more frequently restricted participation to those aged 18 or older or required parental consent for minors. And those that primarily focus on education generally included younger adolescents. And in terms of compensation, only 13 of the studies reported compensation for participation, and all were monetary, and there were different structures of compensation, such as one-time payment or hourly payment. And almost all studies explicitly referenced user-centered or human-centered design principles as guiding their development, while 2 did not explicitly name any framework or theoretical approach, but they did describe some of the principles found in human-centered design. So thinking about the impact of leveraging human-centered design for digital health, we see in the studies that there was high acceptability, appropriateness, and anticipated adoption that was reported. Several studies demonstrated strong feasibility and user satisfaction, and several studies also documented that user feedback led to refinements that improved the usability and feasibility prior to pilot testing or implementation. And many features were highlighted and found to be important by youth participants, some being strong privacy protections or personalized and tailored content that reflect their identities, visual clarity, reduced text density, and a few more as well that you see on this slide. And despite the promise of human-centered design approaches, several challenges emerged across studies. So there were difficulties in recruiting and retaining youth participants. There were challenges around the stigma with sexual health, which led to some dishonest or limited honest participation in interviews. Some digital access inequalities were also noted. And another key issue was balancing youth preferences with feasibility constraints. So furthermore, overall, the findings suggest that human-centered design is becoming an increasingly common approach in the development of digital sexual health tools for adolescents and young adults. So most of the studies focus on the early stages of development, which reflects the resource-intensive nature of the process and the relatively recent adoption of these approaches. And although they generally demonstrated strong early implementation outcomes, um, we will discuss some further gaps noted, such as that, apologies, that although the early implementation outcomes were reported, there's limited long-term evaluation of behavioral or clinical outcomes. Youth engagement was front-loaded, and so there wasn't a lot of youth engagement in later stages, such as the implementation or long-term iterations. And the inconsistent reporting of human-centered design approaches potentially makes reproducibility in future research difficult to follow with existing evidence. And the limitations of this study include that there's a single reviewer, which is me, which could increase the possibility of selection or interpretation bias, limited to 2 databases, with gray literature not being included, English language studies being the only language included for interpretation purposes, and all of this together can lead to selection bias or studies and platforms missing. But this means that the findings should be interpreted as mapping of available published literature rather than a comprehensive representation of all work occurring in this space. So nearing the end of this presentation, just to discuss some priorities for future research and key takeaways. First, there's a need for stronger evaluation and long-term impact. And additionally, future research should move beyond one-time consultation and more towards sustained youth partnership. And moreover, intervention should intentionally address structural determinants because few of them address things like insurance difficulties, transportation challenges. And finally, there should also be a focus on low bandwidth and low technology options. So the use of human-centered design in this area is definitely developing and growing. We found strong implementation outcomes, early implementation outcomes. The standardization of reporting of frameworks and theoretical approaches is needed to strengthen this field. And future research should focus on the following, such as scalable implementation and digital equity. And so I would just like to acknowledge many people that played a role in my undergraduate and graduate studies, as well as this scoping review specifically. Here's a list. As I'm running out of time, I could definitely provide a longer thank you, but here are some names of people that I would like to thank specifically, and also family and friends and the Baltimore community as well for fostering an enriching environment for the last 5.5 to 6 years and for supporting me throughout. So thank you, and I'll take any questions.
Great job. Thanks. We have a couple of minutes for questions. So what questions does our audience have? Ndadwa?
Hi, thanks again for that presentation and congratulations. I was just curious whether the scoping review was specific to the United States or a certain region. Yeah.
Yeah, so that's a great question. So studies were included from all across the globe, but definitely with the background information, there was more focus on the United States. The idea of this scoping review stemmed from a current study that my reader is working on that is specifically focused on adolescents and young adults in the Baltimore area. So I was definitely having a little bit more of a focus on the United States, but evidence and implementation outcomes and all the gaps and key takeaways were from studies across the globe.
Thank you.
Thank you.
Time for one more question. I'll ask, did you come across any particular apps or innovations that came from using the human-centered design, like anything specific that you found that seemed to work really well, at least initially, like you're saying?
Yeah, definitely. Overall, the tools that incorporated gamification did a really good job, and there was one specifically called Peer Nija, that had like peer chat rooms, and you could change, like modify your avatar, and there were like rankings, kind of as like a social incentive that youth participants really wanted. And the funny part is that in one of my practicum experiences, I actually learned about that study prior to starting this work. And the PI working on that study is at the organization that I was at. And then I came across this and also remembered it on my own, knowing that this was something I could maybe incorporate in my scoping review.
Nice, thanks. Well, congratulations again. Great job. Thanks for sharing your work. We'll move now to our third of four presentations from Valentina, who again has an undergraduate degree in public health from Johns Hopkins and will be presenting on uterine fibroids and placental abnormalities. So take it away, Val.
Awesome. Okay, sorry, I am with a dog right now as well, so apologies if there's barking intermittently. Can you see that?
Yep, we can see it, and no dogs can be heard.
Okay, great. Okay, I can start then. So, hi everyone. My name is Valentina, and my master's essay examined the relationship between uterine fibroids and placental abnormalities in singleton pregnancies. So this project was primarily conducted as a scoping review for the master's essay in order to evaluate the current state of the literature. I did mostly want to highlight gaps that remain in the evidence in order to inform my own study on this that I'm working on right now. And this topic is a little niche, so I'm going to start with some brief background before going over the review that I conducted. So, uterine fibroids, if you may have never heard of them before, are the most common benign gynecological condition and tumor worldwide. They arise from the myometrium, which is the muscular tissue of the endometrius in the uterus. In the US, their lifetime prevalence estimates suggest that around 70% of women will develop fibroids, and that number is even higher among Black women, where it is around 80%. Fibroids are the leading indication for hysterectomy in the US, and they are identified in around 3 to 12% of pregnancies via ultrasound screening. The management of fibroids during reproductive years often focuses on fertility preserving treatments. So, myomectomy or uterine artery embolization are very common. And this is in comparison to the most definitive treatment, which would be a hysterectomy. And these procedures are chosen by patients because they allow individuals to retain their uterus, but they don't ensure that the fibroids won't grow back, and they can also lead to uterine scarring. So, on the flip of that, on the outcome, I focused on three major placental abnormalities, and the first is placenta previa, which is when the placenta implants too low. So on here, you see it down here. I think it's because of these graphics, you see these both down here, but a normal placenta would implant somewhere around up here, hopefully, because this is the cervix. And so previa is when that placenta either partially or completely covers the cervix. The second outcome is placenta accreta spectrum, which I'll just refer to as PASS. And the reason it's called a spectrum is because it refers to abnormally deep placental attachment into the uterine wall, and there's essentially like three severities for that level of depth. And in both these cases, the placenta does not detach normally after delivery, and PASS is also associated with prior uterine surgery or scarring, like we were saying. So the third outcome that I looked at was abruption, which is probably the most well studied, and it occurs when the placenta prematurely separates from the uterine wall before delivery. And among these outcomes, abruption typically carries the highest risk for both maternal and fetal complications. And although these conditions are all clinically distinct, they do all involve abnormal placentation, which is why they were examined together in this review. And one note is that I did intentionally exclude preeclampsia, which is another common condition that affects the placenta as well via hypoxia. But long story short, it's more clinical in nature, and there's a compounding presence of established gestational hypertension. So I felt it would really overcomplicate the scope of this review itself. And then lastly, for background, I do think it's helpful to consider how fibroids might relate to placental abnormalities before we get into all the literature about it. And the importance of this study is that it's not well studied, but on the flip side of that, it can get a little bit complicated and the mechanisms are hard. So just very simply put, during the first trimester, pregnancy is characterized by significant hormone changes, including increases in estrogen and other growth factors. Fibroids are estrogen dependent. They grow in the presence of more estrogen. So this environment essentially promotes fibroid growth during early pregnancy. And importantly, placental development also occurs during this earlier period and relies on proper implantation and vascular remodeling at this maternal fetal interface you see. So you can imagine when a fibroid is present along this interface, it's very simply like a huge pebble blocking a stream. And particularly if these fibroids are large or located near the implantation site, they can lead to distorted uterine anatomy, atony, and disrupted local blood supply, which can all lead to the three outcomes that I was looking at. And those typically are diagnosed or occur between the second and third trimester. So I think this topic sits well within the broader context of maternal health inequities. Both uterine fibroids and placental complications are associated with serious maternal morbidity and adverse fetal outcomes. This include ICU admissions or postpartum hemorrhage. Importantly, these conditions show disparities in their distribution. For example, Black women tend to experience fibroid onset about 10 to 15 years earlier than other populations, and they often have a higher fibroid burden and symptom burden. They also experience higher rates of certain placental complications, including roughly a 30% increased risk of abruption. And these disparities reflect broader structural determinants of maternal health. And because of this, understanding whether fibroids contribute to complications can have implications for risk counseling, prenatal surveillance, reproductive planning, and equitable maternal care, just to name a few. So accordingly, my goal was to conduct a scoping review of the literature examining whether uterine fibroids are associated with major placental abnormalities. I used PubMed, Embase, and Scopus in my search terms. This is not an encompassing list, but included several combinations, essentially, of uterine fibroids or leiomyomas, along with terms related to placental abnormalities. I started in PubMed with mesh terms, and then I was able to translate that PubMed query pretty transiently to the other databases. Only singleton pregnancies were included due to known differences between placentation in multiple gestation pregnancies, and studies were included if they evaluated placental outcomes among individuals with uterine fibroids and included a comparison group without fibroids. As mentioned before, the outcomes of interest were previa, PASS, and abruption. And within the literature of maternal health outcomes, this is usually under an umbrella term. So specific outcomes are usually reported as secondary, which is why I said they could be reported as primary or secondary. During data extraction, I recorded standard study characteristics along with many other variables, but there are three that I really wanted to highlight in terms of how study design can impact findings in this case. And the first was fibroid characterization. So that included whether studies reported size, number, or location of fibroids. These characteristics can plausibly influence exposure or the severity of the outcome, but they're not consistently reported. The second was the timing and modality of fibroid detection, such as whether fibroids were identified during routine ultrasounds, screening, or afterwards through like chart review imaging. And then the third was covariate adjustment, particularly for variables known to be associated with both fibroids and placental outcomes. And these include maternal age, BMI, hypertension, and parity. So across my included studies, they were most frequently retrospective and a lot of the significant studies stemmed from ultrasound, but there was a division between ultrasound-based cohorts, whether that be within a smaller institution, and then we saw these larger study samples usually using population data sets and coding or chart reviewing. Most were conducted in the US or Asia, and the biggest takeaway, I think, between the study demographics was that across most studies, the fibroid groups had a higher maternal age, which can impact both our exposure and outcome. So that's just something to keep in mind. 9 used ultrasound, 4 used the administrative or historical diagnoses. And only 2 reported gestational timing of detection. Similarly, only 8 used adjusted models, which was slightly discouraging to hear because it did limit our ability to look at these causal factors such as hypertension or BMI and really try and place where they are. The fibroid phenotyping reporting similarly varied, where only 9 out of the 16 reported either size, number, or location. The most common was number, but again, none of these were included in adjusted models. And then I also looked to see if they classified symptomatic versus asymptomatic fibroids, because if you think about all the women who have fibroids, most of them probably don't know, and those who do know are more likely to be symptomatic and get the diagnosis. But that was not included in any of the 16 studies that I looked at. In terms of our placental outcomes, overall, placenta previa and abruption showed up the most frequently with 10 respective studies. Previa did show the most consistent association with uterine fibroids, and while evidence for abruption was more inconsistent. And some studies reported associations and others did not. You can see here that it's out of 10, 6 reported significant. And this was how the author's reporting. So this could be p-value reported, odds ratio, or relative risk. And sometimes it was simply just prevalence and a standard p-test. I think interestingly, PASS was rarely evaluated, with only 1 study examining this outcome directly. And then I also had an additional study that merged all 3 into 1 composite placental abnormality umbrella. And that just did not allow me, they were significant in result, but it didn't really allow me to break it down through these clinically distinct placental abnormalities. Interestingly, studies using large administrative data sets based on diagnostic codes were more likely to report an association, but the timing was not reported at all. Whereas in contrast, these smaller ultrasound-based cohort studies often did not observe consistent associations, and no study evaluated fibroid position relative to the placenta or implantation site, which further limits biological inference. In a bunch of different ways, I just said the main takeaway, which is that there is not enough evidence and it's too heterogeneous, or there's too much heterogeneity within the characterization of both fibroids and the outcomes. And it leads to the evidence being inconsistent. The differences in reporting size or number and location, as well as analysis strategies, varied very similarly, and many studies were also underpowered for these relatively rare outcomes, with cohorts between like 1 to 10,000. And you just, no matter how many times that outcome would probably come up relative to its biological prevalence, it probably would not prove to be significant in a relationship. So all to say, future research would benefit from standardized fibroid reporting, which is what I'm currently doing right now, and then larger longitudinal cohort studies with consistent outcome measurement and adjustment for the relevant covariates is really important to better understand how risk and certain comorbidities, such as hypertension when you enter pregnancy, can interact with your risk planning and conversations with your own clinician. I have a lot of people that have helped me with this project and are still helping me with this project, but very quickly, I'd like to thank my lab mentors, which, sorry, I do not know why it's going so fast, but My lab mentors, which are Dr. Borhe and Dr. Seegers, my essay readers, my primary essay reader was Dr. Moreau, and my secondary essay reader was Dr. Wong, as well as my advisor, Dr. Cardona. And then I did have a secondary article screener, so I'd like to thank her. Her name's Alvina. She's in the School of Medicine. And yeah, the work is definitely not done, but that was my essay project.
Thanks so much. Great work. Again, we have time for a question or two from the audience. I have a question. Carolina, go ahead.
Hi, Valentina. Congratulations. Great job presenting and summarizing all of this work. So I had just a general question because I know that this is also I guess, parallel product of your experience with the field placement and of your plan moving forward. So I don't know if you want us to comment that a little bit of what was it like.
Yeah, thank you. Yeah, this was kind of like the culmination intersection. My field placement was primarily in a wet lab with uterine fibroids, but I was actively trying to bring public health into that space. And this is one of the avenues in which I chose to do so. In terms of my looking forward and building on it, I hope to complete an actual review on this, including placental abnormalities with the help of Dr. Wong in the Boston birth cohort. But I also hope to expand it to other conditions because I think all of the limitations I found with the cohorts used, that this data set really does help to address in certain ways, such as like a standardized and verified fibroid diagnosis by screening. And then I guess in terms of how this fits into my big future career, the intersection I think I've been most interested in with public health is where it intersects in a clinical space and how that translates into treatment planning and conversations with patients. It's a space I want to go into. I want to become a clinician. So this was just a really great exercise in a very real problem that women face in the US that I didn't know super much about beforehand.
Thanks. I'm thinking about all the first year students that we have on, and do you have any recommendations or tips for the process that you went through to like refine your search strategy or think about the indicators that you really wanted to focus on for the review? For somebody going into a scoping review like this, what would your advice be?
Yeah, you're gonna search a lot. I met with a librarian, which was probably the most helpful piece. She really helped me start that beginning strategy and get a good I feel like everyone in our department has done reviews before, but the size of my review was a little bit newer for me and handling multiple databases. So meeting with the librarian, using Covidence, for example, to track your stuff. And then for me, I'm not a clinician. I'm not in this reproductive space. And so talking to doctors who see the placental abnormalities and handle that and do the treatment for it was really important to get their side of it.
Great, thanks. So another plug for using our library services.
They
Thanks.
are very helpful.
Great job. All right, thanks so much for sharing. And we'll move now to our last presentation from Colette. Again, a Johns Hopkins graduate for undergrad, majoring in public health, and today she's going to talk about overdose prevention.
Can everyone see my screen?
It's coming up, I think.
Is it like presenting mode or like that? Can you see it now?
Now we can see it and it looks good. We don't see
Okay.
your notes.
Awesome. So hi everyone, my name is Colette, and today I will be discussing overdose prevention for women in the US and Canada. And I conducted a systematic review of barriers, needs, and gender responsive gaps in the fentanyl era. And I want to thank Dr. Susan Sherman and Dr. Laura Nicole Sisson for their support and mentorship throughout. Okay, so North America has been disproportionately impacted by fentanyl in the past couple of decades. Fentanyl is a synthetic opioid with a potency up to 100 times that of morphine. US prescription opioids really peaked. The fills really peaked around 2011, partially due to Purdue Pharma's pushing of OxyContin as a non-addictive painkiller. So around 2011, a lot of prescription restrictions were passed in the US, which meant that a lot of people who were addicted to these pills turned to street drugs where it was cheaper and more potent. At the same time, the US was really cracking down on the drug trade between the US and Mexico, which meant that fentanyl was becoming easier to smuggle and it was coming in from China. So around 2013, fentanyl really began to heavily infiltrate the US and Canada. And by 2022, the US overdose fatality rates ranked #1, with Canada just behind at #4. So there have been several literature reviews on the unique challenges that women who use drugs face when seeking treatment and harm reduction services for drug use, such as stigma, the cost, transportation, and limited resources for women like domestic violence and childcare. However, there has been no literature review on US and Canadian women's barriers and needs for harm reduction services within the fentanyl era. So I really narrowed the scope down to examine specifically overdose prevention interventions due to fentanyl's high potency and high risk of overdose when using. So the question of interest today is what barriers, needs, and gender responsive gaps do US and Canadian women who use drugs face with regards to overdose prevention interventions? And I examined 4 interventions. So the first was safe consumption sites, which are sanctioned facilities where people can use drugs under the care of a medical professional in case they overdose. Naloxone kits, which is a medication that can reverse an opioid overdose. Drug checking tools and services, such as fentanyl testing strips and drug checking sites, which can allow someone to check the contents of their drugs, and digital overdose response technology, which include hotlines and applications where people can be monitored digitally while using drugs, and in case of an overdose, an operator will call an ambulance to their location. So my search strategy was a systematic literature review using Prisma guidelines. I searched PubMed, Scopus, and Google Scholar. I included studies that had been published from 2015 to 2025 with data collected no earlier than 2013. I examined US and Canadian women. The articles could include men and non-binary individuals. However, they had to primarily focus on women or at least stratify for gender. The drugs examined had to be illicit or not as prescribed, so I'm not including alcohol, tobacco, or marijuana. And each review had to examine knowledge, utilization, barriers, and or needs for at least one of the specified interventions. So the results were 19 publications, 12 were from Canada, 7 were from the US. A total of 23 interventions were examined, as several articles examined more than one intervention. Safe consumption sites were the most examined, whereas drug checking and digital overdose response technology were the least examined. And the sample sizes really ranged from 14 semi-structured interviews all the way up to 36,000 safe consumption site visits examined. So with regards to safe consumption sites, men were actually more likely than women to use these sites. Women frequently cited barriers like violence and harassment from men, theft while in an intoxicated state, and then concerns about child protective services. They also reported that these sites were male-dominated and male-centered, so there was really a need to increase staff presence for women's safety, especially female staff. And women also requested women-only hours and sites. And they also requested a need for culturally responsive, peer-led, and parent-supportive sites. Indigenous women in particular documented high barriers in the Canadian studies. With regard to naloxone kits, women were actually more likely than men to have received, possessed, carried, and administered naloxone before, although overall use was still low. Women who used drugs that were living with children were actually less likely to have naloxone training, whereas the opposite was true for men. So the barriers were that there was really a lack of knowledge about the importance of naloxone or where to obtain it in the first place, and that caring for children and CPS concerns were a barrier for women to obtain naloxone kits. So there was really a need for increasing naloxone education and access to improve awareness and availability, and there was a need to incorporate childcare into naloxone services. With regards to drug checking, one study examining fentanyl test strip use found that there was no significant difference between genders. Another study that examined that gave women who use drugs who also sell sex, they gave them fentanyl testing strips at baseline and followed up with them to see how many had used it. Only 10% had used them before baseline, but at follow-up, 84% had used these strips and 72% said they were extremely likely to reuse them, which indicates that these are an acceptable option, but there really is a barrier to the initial access and awareness of these strips. Women who also were trying to use drug checking sites reported high levels of stigma as a barrier to use these sites, as well as CPS concerns for mothers who wanted to use these sites, especially in rural areas where visiting these sites in person could really increase their visibility and risk for having their children taken away. So there was a need to expand mobile drug checking services, as well as on a larger scale to reform punitive systems like drug criminalization and CPS. Finally, with regards to digital overdose response technology, they found that women and gender diverse individuals were far more likely than men to use overdose response hotlines. One study that examined women who were living in a supportive housing with an overdose button system found that a lot of women improperly used this system. So how it worked was that within the building, you would press a button if you were about to use drugs, and then soon a staff would check on you and be able to administer naloxone in case of an overdose. But most women were pressing the button after using drugs or after they felt like they had used too much or if they saw another woman overdose. So that really indicated that women were using it as a reactive strategy rather than a preventative strategy, which indicated that there was a barrier to knowledge of how to properly use the system. Other barriers to the button system was that the button required a lot of money to install, to maintain, to have 24/7 staffing to be able to respond in case of an overdose. In addition, female sex workers feared eviction from using the button as it would increase their visibility. So there was really a need to tailor the button's design and implementation to marginalized communities, as well as increasing awareness and access to hotlines and digital overdose response applications for women, as this was suggested as a very acceptable form of intervention for them to use. So there were several limitations to my review. First of all, it was just one reviewer, me, screening each article, so there was no cross-checking or consensus between multiple reviewers. There was also limited generalizability. There was a small number of studies included due to the just very specific criteria that I was using for inclusion. And there were small sample sizes because a lot of these studies used in-depth interviews with women. So there were also a wide variety of populations used and study designs used, which really, again, limited my ability to generalize these findings to all women who use drugs in the US and Canada. And then finally, there was possible underreporting in some of the included studies. Women frequently cited stigma and fear as barriers to accessing resources, so it would not be surprising if they were withholding information from researchers when reporting their true needs and barriers due to stigma and fear. But overall, overdose prevention interventions must consider women who use drugs barriers and needs, and there is a need for further research for how to best implement women-centered approaches into current and future overdose prevention interventions. And so these are my references, and I want to thank everyone for listening, and I want to know if anyone has any questions. I'm going to stop my sharing.
Thanks so much. Great work. What questions do you all have? Maybe I'll just kick us off with the similar question to what I asked Val in terms of like, do you have advice for students who might do this type of review for their essay?
What Val said was that she used a librarian. I did not use a librarian, so I was very like lost and had to do a lot of Googling. That might have been a much more efficient strategy to just like go directly to someone who's like done it before. So I definitely recommend using a librarian for this. It's going to be a lot of work. Like she said, I had to screen over 1,000 articles by myself. So just having another person to be able to screen it would be really useful. So yeah, be prepared for a lot of work, but it's also a very fulfilling experience being able to kind of like do it on your own.
Thanks. What other questions do people have?
So I have a question.
Yeah,
So what were, I guess, like your motivation for doing this type of, like getting into this topic specifically, especially about something that is pretty stigmatized?
Yeah, so for my field placement, I work under Dr. Susan Sherman in the HBS department. So this is very much aligned with the work I'm doing right now in harm reduction. I'm working on 3 different harm reduction studies. And when I was coming up with the original topic, I knew I wanted to focus on something that was related to my field placement, but I didn't know exactly what topic to use. So I went to one of my bosses, Dr. Laura Nicole Sisson, and she recommended that I focus on women specifically because there is not as much research about women's needs in particular out there. So I really just kind of wanted to focus on the work I was doing now, but in terms of narrowing it down, I kind of asked my boss for the gaps in the literature, and that's how I honed in on women.
Thanks. That's really interesting to hear how you tied your field placement to your essay, like not super directly, but based on your area of interest and how you got help from people you were working with to narrow the topic. Oh, I see a question in the chat. Do you see that? Did your
Yes.
articles discuss naloxone?
Sources of naloxone training. They There was like I think 1 or 2 articles that I included that discussed naloxone training, but it was pretty general. They didn't I From what I read, they didn't just like go in on how people were trained. They just asked if people had been trained in naloxone. Naloxone is very easy to be trained in. It's the instructions are on the pack, especially just like the sniffing naloxone rather than the injectable naloxone. So no, in the studies that I included, um, they didn't specify how people were trained in it. They just asked if people had been trained before or had used it before.
All right, thanks. Well, I think that concludes our session for today. Huge thanks and congratulations to our 4 presenters. It was so interesting to hear about your work. So let's all give them one last round of applause. And if you, hopefully you will come to the continuation of these sessions toward the end of term 4 in late April or early May. So stay tuned for those invites. But once again, congratulations and great job, everybody.